Welcome to a special edition of The Impact Equation. We're delighted to be working with our friends at 100x Impact Accelerator on this new series, Scaling Tomorrow's Social Unicorns. Join us as we dive into a 4-part series featuring 6 trailblazing social entrepreneurs who are transforming their communities around the world. 100x is based at the London School of Economics, and applications are open for the next cohort this September. Find out more at 100ximpact.org.
We like to keep things lively at the Impact Equation, and so for a slight change, I'm delighted to swap out Rafi for our good friend Maddie Phipps-Taylor, who joins me today as a co-host. Maddie is a mission-driven leader at the intersection of healthcare and tech. Maddie's experience includes the Cabinet Office, number 10 Downing Street, where she advised the Prime Minister on health and life science policy, and most recently, she was CEO of Eva Health Technologies. Maddie is passionate about using digital to improve the quality, accessibility, and efficiency of health and care services. She is the perfect fit for today's guest.
Thank you, Adam, for the warm welcome, and I'm delighted to be here on the Impact Equation.
Amazing. So today we're joined by Dr. Nick Laing, a public health doctor with over a decade of experience managing rural health centres in northern Uganda. Nick's journey began with the stark realisation that millions in remote areas lacked access to any healthcare, public or private. Determined to change this, he co-founded OneDay Health alongside Emma and Pranav, bringing high-quality, affordable primary care to those living in healthcare black holes. With a medical degree from Otago, a postgraduate diploma in tropical medicine from the London School of Hygiene and Tropical Medicine, and a master's in public health from Cambridge, Nick combines world-class expertise with deep on-the-ground experience. With OneDay Health centres treating over 300,000 patients, Nick is now focused on scaling this model across Uganda and beyond. Nick, welcome.
Awesome. It's great to be here. I think you've said it all. We can go home now, Adam. It's great. I love it.
Let's go back to the beginning. Let's go back to where it started. Tell us about what got you into medicine in the first place and how you took that from a medical degree into public health.
Sure. Well, I think it actually started when I did badly at maths when I was 16. I wanted to be an engineer, but I did really badly in calculus. So I decided to try medical school. I wasn't thinking big. I wasn't thinking about helping people. I just had good parents and a great childhood, and I kind of fell into this profession of helping people, which I was really lucky because it fits my kind of social inquiring personality. And when I started medical school, I actually had tutorials almost every day of the week, apart from Tuesdays. And on Tuesdays, our church had a justice group. And that's where I first started to think about justice, impact, using my life for something bigger, I suppose. And I'll never forget the first group, the leader, Jo, she asked this question. She said, yesterday, I said I'd give my friend a pack of cigarettes if they raised $50 for World Vision. Do you think that was a good idea or not? And that's kind of stuff got me thinking. And by second and third year medical school, I kind of realized that maybe I could do more with my life being a doctor somewhere other than New Zealand. And to cut a really long story short, I met my wonderful wife who did her master's here in northern Uganda 11 years ago, and we moved to Gulu, and it's been an awesome journey since.
Tell us a little bit about the experience of living in Uganda.
Yeah, I mean, first, it's been crazy to see how development is real. I mean, in the last 11 years, we've seen there was no tarmac roads when I first came here. Now there's roads in 5 different directions. Healthcare has got better, more people are in education. So there has been improvement, but it's still one of the poorest places in the world. Most people are living in huts. A good proportion of kids don't get enough food. Over half of children get out of school without being able to speak English, which is the main language here in Uganda. So it's an amazing mix of both progress and still a place which is really unfair. People here just don't get the opportunities that I had growing up.
Before we get into the story of OneDay, tell me a little bit about sort of things that have inspired you, any books, any mentors, anyone who you particularly look up to and value their contribution to how it's affected you and your journey.
Well, my biggest inspiration here is all of our nurses, our OneDay Health nurses, especially Emma, my amazing co-founder who I've been working with here for 8 years now, because in Uganda, there's endless intelligent and motivated and capable, caring people, and they have to wade through the muck and fight against all the odds just to complete the education, let alone get a job at the end of all that. And I really encourage you to let to hear Emma tell his own story on the LSE Summit Day YouTube video last year. You can find that online, but I'll share a little bit of it with you. So he was born one of 7 kids deep in rural Limwo, and he was 20 kilometres from any health facility. And because of this, 2 of his siblings died of diseases, infectious diseases that could have been cured if there was a health centre closer. And because of this, he was super motivated to become a nurse. And so he went to nursing school. But at the end of nursing school, he couldn't pay his fee and get his papers. But they'd take him in South Sudan, which was a conflict zone at the time. And so he worked in South Sudan for a couple of years before coming back. And that's where I met him, and we just clicked quickly and started working together, managing bigger health centres. And it was as we were moving between these bigger health centres, we started to notice these healthcare black holes. And that's where the idea for OneDay Health was born. But there's 2 other doctors who are big inspirations over the years as well. One's a guy, Paul Farmer. There's a great book written about him called Mountains Beyond Mountains. And they founded an organization called Partners in Health, which has been instrumental in getting HIV care worldwide, TB testing worldwide. And he had this belief that it's possible. There's enough resources for everyone in the world to have access to healthcare. And that's been a big inspiration. Second doctor is kind of the opposite, a New Zealand guy, Edric Baker. And there's a great book about him too called Dr. Brother. And he spent his whole adult life in a tiny place in rural Bangladesh running a hospital. And he never received any awards in New Zealand, although he is quite famous in Bangladesh. And he lived in one room his whole adult life on $100 a month, and he trained up local people with no healthcare training to run the super cheap, like OneDay Health cheap hospital in Bangladesh, and he's been a big inspiration to me as well. And I think there's huge value, both to thinking big and global health, and also really digging into communities and understanding problems.
So as we start to talk about your journey with OneDay Health, I wanted to just start with maybe a superficial but maybe quite deep question. What does OneDay Health, what does the name OneDay Health mean to you? Yeah,
well, we chose the name for 2 reasons. First, because we have the dream. What OneDay Health is all about is that one day everyone in the world will have access to quality healthcare. And also second, that with each OneDay Health Centre, we get one step closer to that. And it's an urgency thing. One day, we can actually launch a OneDay Health Centre in one day. We throw all the equipment, the solar unit, the drugs, the cupboards, everything on the back of a truck, and one day we can get started. So it means those 2 things.
So, Nick, I wonder if you could tell us a bit more about the OneDay model. What makes it special? What makes it unique?
Sure. Well, first, not trying to kind of, blow our trumpet or anything, but there's actually very few organizations even trying to bring comprehensive healthcare into truly remote places. So just doing that in truly remote places is actually surprisingly unique. There's a community health worker movement, which is really big, and that treats a lot of children under 5, but providing a universal healthcare for the whole population, doing that is actually a pretty unusual thing. But stepping back, there's 100 million people in sub-Saharan Africa, like Emma when he was younger, living in what we call healthcare black holes, places with poor access to healthcare. And when they get sick, they don't have any good option. They can pay a lot of money and travel a long distance to get healthcare, or they can stay at home and hope they get better. And I always say the human body is a beautiful thing, but sometimes without the help of modern healthcare, it can't make it through. So what we do to solve this problem is we launch small nurse-led health centres in these healthcare black holes, which for the first time give people a comprehensive healthcare option. And what makes us unique, we've got this idea, we call it a scalable healthcare architecture. That gives us the ability to launch and to manage large numbers of these health centres. And it's built on these 4 pillars. The first is that we're tech-enabled. We've got this amazing AI-powered mapping tool called Health AIM, and this helps us rapidly identify healthcare black holes. It's super, super cool. And second pillar is that we're comprehensive. It's just one nurse in a rented building, and they can do basically everything your GP can in a clinic in London. They treat acute diseases like malaria, pneumonia, chronic diseases like high blood pressure, diabetes, and of course empower women to take control of their reproductive future through family planning and antenatal care. So second, we're comprehensive. Third, really important, we're high quality. We've got these great flowchart-based clinical guidelines which cover the 30 most common conditions in the areas where we operate. And that covers over 95% of the disease burden. And through these guidelines and our monthly support supervision system, that means our nurses get the diagnosis and treatment right. So we're high quality. And fourth, and this is something I'm super proud of, is that we're cost effective. It costs only $4,000 to set one of these up. It's the medications, the drug cupboard, the solar unit, the desks, all the tests, all that kind of stuff, and the rental building. And then the fees are paid for, small fees by local people. So it's about between $1 and $2 that people pay, and they're locally sustainable. So just how it's one of the most cost-effective ways we think to save a life and to provide healthcare in the world. So those are our kind of 4 pillars, which when come together, they make us a unique thing.
So Nick, once the facility is up and running, you're saying that the ongoing cost is fully sustainable and fully paid for by the local community?
Yes, that's the plan. And at the moment, about 3/4 of our facilities are at least fully paid for or make a small profit. And then 1/4 of our facilities aren't there yet. And what that means is that we can take donor funding and port it into launching new facilities, which is a great thing. It is a really tricky thing to talk about, though. These are some of the poorest people in the world, and we're asking them to pay money for healthcare. But people really appreciate it. And when we ask people, is this too expensive? People say, no, it's really reasonable. Even though it's hard, is because if we weren't there, if OneDay Health wasn't there, they'd have to pay for a motorbike to travel a long distance to get to another health centre. So the whole reason our model works is because it's cheaper for people to come to healthcare with us than whatever their other options are. And so people are really happy. They save money. They have more money for livestock and for farming inputs and for school fees. Yeah.
Can you give us a sense of what a typical day looks like for you and for Emma running OneDay Health?
Yeah, so we have 6 managers actually running these 52 health centres. So each manager runs a hub of 6. So we'll often get up and talk to the managers, see how their health centres are doing, deal with any issues that are happening. Sometimes we'll go out and visit one. So we jump on a motorbike and head out 2 hours on a dusty road to see a OneDay Health centre. We visit some members of the community, ask what they think about the health centre, how it's doing. Then we go to the health centre itself. We check the quality, we check the finances, that all that stuff is good. Obviously, these days we're doing more and more outward focused stuff as well. Things like talking to you, obviously talking to funders, that kind of stuff, and then trying to build our systems, trying to make sure that our quality systems are better, trying to move as many things electronic as we can. So we've got great electronic quality control dashboards now. We've got an electronic mapping tool, and the next phase is trying to move our nurses into using digital tools as well. So those are some of the things we're doing in a typical day.
There must be lots of, difficulties and challenges that we have absolutely no idea about over here. Could you talk us through some of the difficulties that you encounter in rolling out a healthcare facility?
Yeah. One thing I'll say is that actually setting it up is not as difficult as people think. People think that's going to be one of the big challenges. It's not actually one of our biggest challenges. The biggest one is just that people are really poor. We're operating in the 5% of the most remote places of Uganda. And we're asking these people who are almost all subsistence farmers, earning a few dollars a day at the most, some less than $1 a day, to pay for healthcare, which is really, really tough. And that's a struggle. So that's definitely one of the struggles is that the good thing is that people think that our prices are good and they think it's fair, and they say this saves us money. So we have this interesting kind of conundrum where people say it's fair and they're really happy, but still sometimes they don't have enough money to pay. So that's a big challenge. Another huge challenge is referrals. What do we do when people are really sick and they need to go to a hospital? And this is something that we haven't solved. You've just interviewed Neha at IntelliHealth, and we'd love to get some IntelliHealth input, which could solve some of that problem. But there's always going to be people with appendicitis, delivering babies, who need to go to healthcare. And when it's 10 p.m. at night and it's raining and the road's flooded and someone's just been bitten by a snake, I mean, it's not going to end well at the moment. And until you have roads and until you have, better infrastructure, it's some of the things feel almost unsolvable at the moment, but we'll see.
Can I ask about workforce and the challenge around, as you've already talked through, Emma's story and how he got access to nursing education, but obviously that's a challenge for many people to get access to. As I understand it, there's, like in many countries, a trained professional healthcare workforce shortage in Uganda. So how do you see yourself playing in that, in the sort of the wider workforce space, and how do you encourage people to come and work for you?
Yeah, so I'm actually going to push back on that a little bit, Maddie, if that's all right. I'm not sure there is so much of a global healthcare shortage. There's a jobs shortage. In Uganda, there are thousands of unemployed nurses. In Nigeria, there's tens of thousands of unemployed nurses who are pouring into the UK because they can't get jobs in Nigeria. So there's actually there's thousands of unemployed nurses. We get 50, 100 applications for our jobs, and we can actually select the best nurses to work for us. So it's a great thing we can do is actually provide jobs for this huge pool of unemployed nurses in Uganda. I actually think sometimes there's not enough trained positions, but in a lot of countries, the problem is actually more the jobs than the number of trained people. So it's a great opportunity we have to take these amazing, talented, motivated nurses, like I was saying, and give them often their first real job and upskill them and give them opportunities in the future for promotion within OneDay Health. Some of them can get the opportunity to join, more high-flying jobs, maybe for NGOs. So it's one of the wonderful privileges we have is to be able to give people jobs, meaningful employment, and really empower them for their futures as well.
Nick, can you share with us some of the stories or examples of the impact of the work you guys do?
Sure. There's this wonderful woman, Agnes, who always comes into my mind. She's in her early 40s, and when we were talking to her, she's sitting there on the dirt beside her hut with her two twins, and they were looking really, really happy while they were telling the story, which had some not so happy elements to it. And they said that before the OneDay Health Centre was there, when her kids would get sick, when they'd get malaria, which would happen a few times in a year, they'd have to travel 10 kilometres. They'd have to pay like $5 to $10 just to get treatment. That might not sound a lot to you, but it's a huge amount to her. And not only that, but she'd be so stressed because she knew her kids were going to get malaria and she knew this was going to keep happening. And the biggest thing for her about the OneDay Health Centre was just the relief. She talked about her kids getting the good treatment and getting better quicker. She talked about having more money to buy animals. She talked about, but the biggest thing was just the sense of well-being and relief that this OneDay Health Centre was there. Another interesting one is this guy who I was actually there, and he came in with anaphylactic shock, and we were fortunate we had hydrocortisone. It's this steroid there at the time, and we're able to inject that in and see him get better very quickly. And just experiencing that, obviously I'm in the office a lot, I don't see much of that stuff firsthand, but just realizing what a difference that makes. And as well as the stories from the patients, just hearing how the nurses and how much satisfaction they can get out of their job is also a huge thing as well.
So thinking about scaling up and scaling the impact, I'm sure you've got great plans ahead for OneDay Health Centres. Just talk to me through about how do you think about scaling, where you go from here, what are the sort of things you need help from, and where are you getting that help?
Sure. Yeah. So we've got 53, I think. I lose track. 53 OneDay Health Centres, and probably another one next week. But this year, we're going to do scale like we've never done it before. We're all ready to launch another 25 OneDay Health Centres this year in Uganda, which is fantastic. And for the first time, expand to Malawi. So we're now across about half of Uganda. And we're trying to look at other places where we could have an impact. It's actually Emma who's super passionate about this. He's like, we've discovered this thing in northern Uganda that's working, this way of providing healthcare, and he wants to share it with more of the world. We've identified Malawi as a possible country. We've got some contacts there, so we're going to pilot for the first time in Malawi this year. But I suppose if I look bigger, if what our dream would be to pilot in a country like Malawi and then go to the government and say, look, we've got our tool. We've identified 100 places we think OneDay Health could provide this really cheap, cost-effective healthcare. Can you join with us in the next couple of years? Let's launch 100 OneDay Health Centres, in Malawi, and let's solve this problem that the country's got. I suppose that would be, a great way for us to scale.
It sounds like you've got a very sort of, obviously scalable model, but financially scalable model. which may seem in contrast to some of the international aid that's going into the space. Now, obviously, in recent weeks, we've seen dramatic cutback in US aid, USAID. Talk to us a little bit about the landscape for, working in a commercial space, but alongside maybe increasingly volatile international aid landscape as well. Is that an opportunity or is it a threat to what you're doing and how you could scale?
Yeah, I mean, it's a big opportunity, but it's a bit of both. I'll also remind you that your country, the UK, just cut 40% of its aid as well. So you can turn your eyes to the US, but also look in your backyard as well.
Yeah, this week indeed.
Yeah, so one really important thing, which is a threat, is that most malaria tests and malaria medications, including most of OneDay Health ones, are given for free by USAID. So this is for government health centres. This is for community health workers. This is for not-for-profit. And that hugely drives down the cost. The fact that the market's basically flooded with this free, and it's been an intentional strategy by USAID. So that is going to drive that. If that disappears, currently it's still going. I do want to say that it's been classified under essential drugs, so it is still going. But if that were to be pulled, that would have a huge impact, partly on us, but mostly on the cost of malaria treatment across the whole country. But like you said, I also think this shows us that we need models which are not, dependent on huge amount of aid flooding in all the time. I always say, if you cut off all donation taps to OneDay Health, we'd keep going for a long time, just as we are the current health centres. So I think it really does show the importance of being sustainable. And although there are disadvantages to user pay model, the stability and the sustainability is an advantage as well.
And Nick, you've worked obviously in other health contexts all around the world. I wonder what you could bring to so-called Western countries and their health systems. What have we got to learn from you and your team?
Yeah, I love that. I could talk for hours about this. I think that, the Western world has a problem that healthcare costs are just rising. They're rising super fast, and it's just becoming impossible. We have this idea that, everyone should see a GP, and everyone should get, the most expensive medication, and it's kind of falling apart. It worked for a long time, and now it's just not working. And so we are seeing health assistants, nurse practitioners. We're seeing other people, who have the ability to see patients. But something very similar to the OneDay Health model, nurse-led healthcare, let's say in villages in England or in rural parts of New Zealand, it is being explored, it is being done in some cases, but I think it's a great model. You could rent small buildings in villages, have a nurse there running things, hooked up to AI help tools, hooked up to doctor referrals. And I think we're not being nearly creative enough about solutions for our healthcare systems which are ailing and just becoming far, far too expensive. I also think that cost effectiveness is just not considered enough. England has traditionally been pretty good at it, thinking about cost effectiveness, maybe a bit less so, but we have to think every dollar that we spend is important. And $1 you spend on one thing, you're not spending on something else. That's the reality. And so we do need to be realistic about some of our treatments as well. And what OneDay Health does is we provide treatment to, over 95% of the burden. It's super low cost, $1 to $2 a patient. So I think, although you want to be aiming for higher because you have more money in other countries, I think maybe we should be looking to some of the innovative models, not just OneDay Health, but all the community health worker movement and all around the world. There's some amazing innovative models coming out of low-income countries that maybe some of the higher-income countries could be drawing from as well.
I'd like to push you a bit further, Nick, because you said you could speak for hours and you've given us 2 examples, but what else? Teach us, tell us, because presumably there's a cultural angle here as well. There's an educational angle here as well. Just don't hold back, Nick. Tell us more.
Yeah. Another thing I really like harping on about is guidelines and algorithms. And you can go a long way with guidelines and algorithms, both for quality and for safety. And often professionals are actually very resistant to algorithms. But for example, in surgeries, a checklist was introduced at the start of surgeries, and it's massively reduced surgical complications. Just having to read through, okay, I took out all the sponges, I didn't leave any scissors in the patients. And even like GPs and this is prescribed drugs that could be 10 times the cost of another drug that would work just as well. So I think like more strict protocolizing and more streamlined, like kind of forcing people to use the most evidence-based cost-effective option. I think that's something that should be implemented a bit more, which can take away some of the choice of the clinician, but can sometimes increase the quality and lower the cost at the same time. I also think that we could be training more health professionals. This is, at the moment, we're kind of the West is trying to solve its health crisis by pouring in health professionals from the rest of the world. And to some extent it works, but it can also, it's already starting to hurt places like Nigeria. So I think they also need to buckle up and do a bunch more training as well. There's a couple more.
This has been quite a journey, and I suppose you've been a number of years on this journey, but maybe even a lifetime you'd consider it to get to this point. When you look back, what do you wish you'd known, or what could you tell yourself as a 20-something-year-old when you started on this journey out of medical school? What would you have liked to have told yourself then?
Yeah, I mean, I think I might have actually told myself to think a bit bigger and be a bit more optimistic. I'm a Kiwi and we have real tall poppy syndrome. And of course, I was based here in northern Uganda, and coming out of the war, there's a real kind of poverty mindset because people don't have very much. They want to keep hold of it and want to, maintain what we do. But and this is where Emma has really helped me. I mean, OneDay Health, we've kind of slowly expanded 5 to 10 health centres a year, and it's only in the last couple of years and through things like 100X that we're thinking of how much we could help the world. So one message would be to be open to thinking a bit bigger and being more ambitious. But also, I'd at the same time, I'd really encourage myself to dig into the community and to move slowly, which we have done to some degree on a personal level, because when you really get to know people, we live in a beautiful community here around us, no walls, northern Uganda. It's just beautiful, and you learn so much about people and healthcare and what people's really pain points are just by really digging into people's lives and community. I think sometimes people try and learn everything through books, and learn everything through research, but there's so much. I have a lot of respect for anthropologists, and people who really dig into to culture and to what makes people tick and to what people really think about healthcare. And I think that really helped us realise what kind of model might work in OneDay Health.
And Nick, so coming towards the end of our time together today, you mentioned expanding into other parts of sub-Saharan Africa. Obviously, you and your team sound like their energy knows no bounds. But what else needs to go right in that jigsaw puzzle in order for you to go from 52 centres in Uganda to perhaps serving a larger proportion of the 100 million people in sub-Saharan Africa without access to meaningful healthcare?
So one thing that needs to happen is that we need to get our model more recognised in the public health world. And there's this amazing story of the community health movement, how it seemed crazy initially to have these very minimally trained people, kind of diagnosing and treating kids under 5, but now it's become a norm and this massive movement around the world. And for OneDay Health, this is one great thing through LSE. We're doing, research on our model, trying to show just how good the quality of our care is. But one step is that we need kind of acceptance and support from public health bodies, from the WHO, from public health professionals in Uganda. So that's part of our journey at the moment, is just being seen and being recognised at that kind of higher level, because we've kind of been plugging away in Uganda for a while. And the second is to build the trust with governments, like we said, because to scale on a bigger scale, we're going to need governments to kind of believe in us and even take a bit of a risk. I don't think it's a big risk, but from their perspective, it's a different model, right? So it will seem like a risk. And so to find governments that are willing to partner with us, that's a huge part of what we're going to need. Those two things, I think.
And you mentioned 100X, Nick. Could you tell us a bit more about the role that the 100X Impact Accelerator has played in helping you guys to think about scale and prepare for it? Yeah,
it's been our biggest thing, our biggest break to date. Actually, of the 10 ventures, I think at the start, we're actually the smallest in terms of our budget, and so it's been a real pull-up for us. They've helped with lots of things. They helped us through the system come up with this, the scalable healthcare architecture framework, which we talked about. They've helped connect us directly to LSE researchers who are now researching our work, which is fantastic. But more than anything, I think, is just that thinking bigger and believing that we can connect with governments. We can really gain that reputation with our model and helping us be more ambitious and think bigger. But it's been a really big step up for us. Yeah.
We talked a little bit about the 1 year journey, and you want to be opening another 25 centres. You want another country, Malawi, which is great. Then you'll be international. Where do you see maybe the 10-year journey for OneDay? Can you just talk me through what would you like to see if you walked into a OneDay Health centre in 2035? What would you like to see in that centre? One thing is that we need to use AI diagnostic tools, and we have a huge advantage with this. It was actually at 100x that Neha from IntelliHealth showed us what was possible here. Because we have these strict guidelines, AI can already use these guidelines to help us diagnose patients. We've just got to operationalize it. Like, the ability is already there. And if the nurses have that tool that they can talk to and it can tell them, direct them where to go, their quality will get even better. So one thing is nurses with an AI assistant is going to be huge. That's what a health centre in 2030 will look like, or maybe even in 2025 or 26. Another thing I'll say is that if we look at, let's say there's 30 countries we're looking at, a bunch of those countries do have solutions, or they're looking at solutions to the remote healthcare problem. So we're not trying to work in every country. We're trying to work in countries which have this issue. And so I'd say, maybe in 2035, you'll be looking at 15 countries across sub-Saharan Africa which have OneDay Health centres that look a bit different, that fit into their health centre in different ways, that are digitally enabled. Some will be run by nurses. Some might even be run by community health workers. Because we've got this model, but we know it needs to be flexible and it needs to adapt to health systems as well. And do you think, from a technology point of view, do you see that there is going to be a need for things like mobile diagnostic scanners and things like that, or do you actually feel that that's, even in 2035, actually what you could do with a smartphone, maybe a tablet, and some very thoughtful decisions around the design of the service, the design of what you stock in terms of drugs and prescriptions? Do you think that's actually, that's where the bulk of the activity is going to remain? Or do you feel like we are going to sort of see increasing sophistication to the diagnostics in a way that we don't see today? I'm actually a bit less optimistic about diagnostic tools. One of the great innovations has been these rapid tests. I mean, everyone knows now the rapid COVID test, where you see the lines of pregnancy test. And you can now do that for a whole range of conditions. And this is actually one of the things that enables OneDay Health centres to exist. For hepatitis, for urine, for diabetes, you can do a blood pressure. For typhoid, all these conditions you can now just rapidly test in a cassette. And that's made a huge difference. One thing is ultrasound. So I think there'll be digital ultrasounds you can attach to a phone, and they'll be able to make the diagnosis for you through AI tools. But right now, we can already provide primary healthcare, comprehensive primary healthcare in these places. We don't need a whole lot more technology to be able to do that. It's just going to help us incrementally get better, I think, yeah. Really interesting. Thank you. It's great to hear that it doesn't have to go to the very sophisticated end to still deliver increasing value and in a sustainable way for populations for whom they haven't had that access before, which is really inspiring. So thank you. Awesome. Yeah, love it.
Nick, final question from me would be, what would you ask of our audience? Is there anything in particular or specific that they could help with in any way?
Yeah, I mean, what I'm going to ask you is not for us. It's going to be to look at your life and really think about how you can have the most impact with your life. I think a lot of people think about it a bit vaguely, and they're following a normal kind of career track. But I really encourage people to think deeply, okay, with my skills, whatever my stages in life, how can I have a really positive impact to the world? That's my kind of challenge to anyone who's listening. And there's a book I recommend called Doing Good Better, which helps us think about that. There's a website called Probably Good, which they actually offer free kind of career counselling, helping you think about how you might be able to do more good with your life. But that's my challenge to everyone, is that wherever we are, whatever your juncture is, really think, with my skills, with my passions, how can I have an impact on my community or the wider world? Yeah, there's my challenge.
Amazing. Well, I think speaking on behalf of myself, challenge accepted, Nick. Thank you. And Maddie, perhaps on your side as well.
Definitely. Thank you. That's really inspiring to all of us. And I'm very privileged to have had some time to chat with you today. So thank you.
Thanks so much. It's been great. It's been fun.
So Maddie, what an amazing conversation. What did you make of Nick and what they're doing over at OneDay Health?
I mean, of course it's inspiring because it's one of the stories of the Impact Equation podcast. But really, I had so much fun talking to him, hearing his passion, appreciating that he's calling us from rural Uganda in a house with a straw roof. Obviously, some challenges with the technology as well, which I think just goes to show sort of some of the in a small way, some of the challenges you face actually delivering services in these environments and doing it with such care and passion and innovation. I mean, genuine innovation in bringing what he's doing to his populations that he's serving. So it's really great to see that. I think he has some really important words of wisdom, including, a challenge to us as individuals. He's so selfless. He's not asking for help for him. He's asking that everyone sort of in their own ways is just more thoughtful, more deliberate, more considered. And I think that's really a credit to him. This is an opportunity right now in the next couple of years for him to scale up for the team. With the changing dynamic of international aid as well, I think that's probably going to have a huge knock-on impact that, I can't even begin to appreciate, but he will and understand it and try and work either around it or work with it to essentially get to a more sustainable health system. As a result, although the journey might be challenging, hopefully actually these sorts of existential shocks will be less frequent in the future when people have got a sustainable and self-funded health system. So really inspiring talking to him.
It was just so interesting. I mean, there are a couple of things that stood out for me. First, the fact that infrastructure costs can be funded and then the local community can fund it themselves. And there are some interesting things there around like the future of health systems in sort of so-called Western democracies where patient populations are getting older. We expect healthcare to be for free. We don't expect to pay for anything. Is that model sustainable? And thinking about, as he said, people are prepared to pay $1 to $2 for treatment because it saves them money. They actively feel that every time they make a decision to use their services. And the other piece in particular that stood out for me was around, again, how they can grow across sub-Saharan Africa. It's an intervention that's working, it's low cost, it's affordable. And really the question to me was, well, what would help Nick grow it faster, go further? And how can we bring back some of those innovations in low-income countries to the UK, for example? It's true, whenever my kids have a problem, the initial reaction is, well, let's take them to a GP. But most of the times, actually, the GP isn't really required. Actually, a nurse or a pharmacist might be a much better place. But that's the model we've built and the model we understand. And I think there are clearly much better ways of delivering care in the UK that can be very much informed by what's happening on the ground in rural Uganda. So there's a huge amount for them to teach us too. So thank you so much, Maddie, for joining us today, for being a much more worthy stand-in for Rafi than I could possibly have hoped for. So a real pleasure doing that with you today.
Well, thank you, Adam. It's been a lot of fun.
Thanks, Maddie.